Chapter 12 Attention Deficit Hyperactivity Disorder and its Treatment. Symptoms and Circuits. ADHD as a disorder of the prefrontal cortex. Noted for a trio of symptoms arising due to abnormalities in the various circuits involving prefrontal cortex. These are inattention, hyperactivity, and impulsivity. The most prominent symptom of inattention in ADHD is better known as executive dysfunction. Is the inability to sustain attention and thus to solve problems are linked to inefficient information processing in DLPFC. The DLPFC can be activated by a cognitive task known as the NBAC test. Problem in activating this part is also seen in schiz, major depression, mania, anxiety, and pain disorders. Diagnosis in psychiatry is now moving from describing categorical syndromes that mix together many symptoms towards categorizing single symptom domains, such as executive dysfunction that cut across many psychiatric disorders, and it is sometimes called the research domain criteria for further diagnostic schemes. Another symptom of ADHD is selective inattention and is linked to inefficient information processing in different brain area, namely the dorsal anterior cingulate cortex. This area can be activated by tests of selective attention such as the Stroop test. Other areas of prefrontal cortex that are not functioning effectively in ADHD are the orbitofrontal cortex linked to symptoms of impulsivity and the supplementary motor area linked to the symptoms of motor hyperactivity. OFC is hypothetically linked to a wide variety of symptoms that cut across several psychiatric conditions such as impulsivity and violence in schiz, suicidality in depression, impulsivity in mania, impulsivity and compulsivity in substance abuse, and impulsive symptoms of conduct disorder, oppositional defiant disorder, and bipolar disorder. ADHD as a disorder of inefficient tuning of the prefrontal cortex by dopamine and norepinephrine. The inability to activate prefrontal cortex is thought to be due to dopamine and norepinephrine dysregulation in ADHD, preventing the normal tuning of pyramidal neurons in the prefrontal cortex. The normal firing of these neurons at baseline is considered slow and tonic, stimulating a few receptors on postsynaptic neurons and allowing for optimal signal transmission. Thus, modest level of any release will hypothetically improve PFC function by stimulating postsynaptic alpha-2A receptors. But high levels of any release will lead to impaired working memory when alpha-1 and beta-1 receptors are also recruited. Similarly, modest levels of DA will first stimulate D3 receptors, as these are more sensitive than D1 or D2 receptors. Hypothetically, low to moderate levels of D1 receptor stimulation is beneficial to optimizing prefrontal cortical functioning. Dopamine neurons also exhibit bursts of firing, called phasic firing, thought to reinforce learning and reward conditioning, providing the motivation to pursue natural rewarding experiences such as education, recognition, career development, enriching social and family connections. When this phasic DA system is hijacked by drugs, it can induce uncontrolled DA firing that reinforces the reward of drug abuse and lead to compulsive behavior such as mindless self-destructive drug seeking. Finally tuning this DA reward pathway in the nucleus accumbens and its connection to amygdala and prefrontal cortex by attaining low levels of phasic firing in relation to tonic firing will theoretically lead to proper functioning in this complex system. Deficient signaling in prefrontal cortical DA and NE pathways is reflected by decreased neurotransmission and thus reduced stimulation of postsynaptic receptors. ADHD is also hypothetically associated with excessive signaling in prefrontal cortical DA and NE pathways. Stress can also cause an excess of phasic NE and DE firing. This is the underpinning of the development of drug and alcohol abuse, impulsivity, inattention, and anxiety, which are all comorbid with ADHD. Either too much or too little stimulation of NE or DA can cause insufficient information processing. To work properly, cortical pyramidal neurons need to be tuned, meaning the moderate stimulation of alpha-2A receptors by NE and D1 receptors by DA. Thus, agents that lead to increased release of these two neurotransmitters or increased tonic firing of these neurons will be hypothetically beneficial. The role of NE is to increase the incoming signal by allowing the increased connectivity of the prefrontal networks, while the role of DA is to decrease the noise by preventing inappropriate connections from taking place. If stimulation at alpha-2A and D1 receptors is too low, all incoming signals are the same, preventing a person from focusing on one single task, that is, unguided attention. On the flip side, if the stimulation is too high, the signals get scrambled as additional receptors are recruited, again misguiding a person's attention. Alpha-2A and D1 receptors are often located on the spines of cortical pyramidal neurons and can thus gate incoming signals. Cyclic AMP molecules link the receptors to HCN-gated cation channels. An open channel will lead to a low membrane resistance, thus shunting inputs after the spine, and the signal leaks out, therefore lost. When these channels are closed, the incoming signals survive and can be directed down the neuron to strengthen the network connectivity. And this happens when any or a noradrenergic agonist binds to the alpha-2A receptor and the activated G-link system inhibits cyclic AMP, thereby closing the HCN channel. In contrast, when DA or a DA agonist binds to the D1 receptor, this activates GS-link system, leading to opening of the HCN channels, leading to leakage of the signal, shunting any input out of the spine. This explains why moderate stimulation of both types of neurons is preferred in order to strengthen the signal-to-noise ratio in prefrontal cortical neurons. So if the systems are properly tuned, then the D1 receptor stimulation can reduce the noise and alpha-2A receptor stimulation can increase the signal strength to result in a proper prefrontal cortex functioning, which will translate into adequate guided attention, focus on specific tasks, and adequate control of emotion and impulses. Neurodevelopment and ADHD. The classic form of ADHD has onset by the age of 7, possibly related to abnormalities in prefrontal cortex connections. Synapses rapidly increase in the prefrontal cortex by the age of 6, and then up to half of them are rapidly eliminated by adolescence. Thus, the selection of synapses for removal contribute to the onset. Those who are able to compensate for these prefrontal abnormalities by new synaptic formations may be the ones who grow out of their ADHD. And this may explain why the prevalence of ADHD in adults is only half that in children and adolescents. Genes that code for subtle molecular abnormalities are thought to be very important to the etiology of ADHD, similar to SCIS. Major genes implicated in ADHD are those linked to dopamine. Environmental factors inevitably contribute to ADHD, such as preterm birth, maternal smoking, and others. Interestingly, inattentive symptoms are not really seen in preschool children with ADHD, perhaps because they do not have a sufficiently mature prefrontal cortex to manifest them. But once it becomes a prominent symptom, it remains so over the life cycle. Interestingly, hyperactivity declines notably by adolescence or early adulthood, but comorbidities skyrocket. Many cases have onset up to age of 12 and some even up to age of 45, the so-called late onset ADHD. And genetic studies suggest that full syndrome ADHD with onset after the age of 7 has similar psychiatric comorbidities, functional impairment, and family transmission to ADHD with onset by age of 7. Interestingly, adult cases mostly have comorbid conditions, that is the focus of treatment, not their ADHD itself. Only 1/3 of all the stimulants used for ADHD is in adults, as practitioners do not like to prescribe controlled substances such as stimulants. And the other reason being comorbid conditions such as substance use, anxiety disorders, and bipolar or mixed states. Augmenting antidepressants and anxiolytics with non-stimulants is therefore preferable. Therefore, much more off-label use of anti-antidepressant bupropion, various SNRIs, and wake-promoting agents, modafinil and R-modafinil is present in adults. Atomoxetine augmentation of antidepressants and anxiolytics can not only improve cognitive symptoms of ADHD, but has the potential of improving anxiety symptoms, depressive symptoms, and perhaps even heavy drinking. The alpha-2A selective agonist Guanfacine ER, approved for use in children, may also be useful in off-label treatment of adults, as can be long-acting stimulants. Treatment. Which symptoms should be treated first? Substance abuse should be first, followed by mood and anxiety disorders. Adults with ADHD smoke as frequently as adults with SCIS, that is about twice the rate of normal adults. Subjectively, it improves ADHD symptoms, especially in patients who are not being treated for their ADHD, as nicotine enhances DA release, thus arousal. Stimulant treatments of ADHD. When both DA and NE are too low, the strength of output is also too low, thus leading to reduced signal and increased noise. Behaviorally, this could translate to a person not able to sit and focus, fidgeting, and shifting attention. Thus, DA and NE has to be increased to optimal levels, which can be done both by stimulants and by some non-adrenergic agents. Theory suggests that first, the stress of suffering from ADHD plus environmental stressors can dial up noise and reduce the signal, resulting in high NE and DA release. But as the stress becomes chronic, both their levels eventually plummet due to depletion over time, but there is no relief in terms of poor signal output. Thus, ultimately, the appropriate treatment is to increase NE and DA concentrations to allow for normalization of behavior. In children, the combination of tics generally represents excessive DA activation in striatum and may require DA blocking antipsychotics. And understandably, it can be very difficult to treat simultaneously in patients with ADHD, who have deficient DA activation in cortex and require DA enhancing stimulants, but consequently making the tics much worse. Similarly, patients with comorbid conduct disorder, oppositional disorder, psychotic disorders, bipolar mania, and mixed conditions, which are theoretically associated with excessive DA activation in some prefrontal circuits, will be most challenging for you, as atypical antipsychotics simultaneously release DA in prefrontal cortex, to stimulate D1 receptors while acting in limbic areas to block D2 receptors, it is sometimes possible to augment these with stimulants, thereby increasing DA release to an even greater extent to act at D1 receptors in prefrontal cortex, thus reducing the symptoms. Understandably, such approach is controversial and best left to experts. For adults with comorbid anxiety, depression or substance abuse, augmenting antidepressants or anxiolytic therapies with a tonic activator of DA or any system such as a long-acting NRI or alpha-2 adrenergic agonist rather than a stimulant can be an effective long-term approach. Methylphenidate. Oral administration blocks the transporters for both NE and DA. It much the same way as antidepressants, that is allosterically, with no action on VMAT. It has a D and L isomer, the D isomer being much more potent. Amphetamine. Amphetamine is a competitive inhibitor and a pseudo-substrate for both NET and DAT, binding at the same site as the substrate. At the high doses used by addicts, additional pharmacological actions are triggered. It is actually transported as a hitchhiker into the presynaptic DA terminals, an action that is not shared by methylphenidate or antidepressants. Once there, it is also a competitive inhibitor of VMAT2 for both DA and NE. It also hitchhikes another ride into synaptic vesicles, displacing DA there, causing a flood of DA release. Slow release versus fast relief, stimulants and the mysterious DAT. DAT is somewhat mysterious, giving one set of responses if the occupancy by a stimulant is rapid, saturating and short-acting, and a completely different set of responses if the occupancy ramps up slowly, has incomplete target saturation and lasts long time. It also has different clinical responses to different routes of administration and doses, and thus to how quickly, how strongly and how completely DAT is blocked. Optimization of ADHD means occupying enough of NET in prefrontal cortex at a slow enough onset and long enough duration of action to enhance tonic NE signaling via alpha-2A receptors, and to increase tonic DA signaling via D1 receptors, yet occupying little enough of the DAT in nucleus accumbens so as not to increase phasic signaling via D2 receptors. Noradrenergic treatment of ADHD. ATOMOXETINE. Atomoxetine is a selective NRI. Since the prefrontal cortex lacks high concentrations of DAT, DA is inactivated in this part of the brain by NET. Thus, inhibiting NET increases both DA and NE in prefrontal cortex. Since there are few NE neurons and NETs in nucleus accumbens, and ADHD patients have weak NE and DA signaling in prefrontal cortex, a selective NRI such as atomoxetine increases both NE and DA, enhancing their tonic signaling, but increases neither NE nor DE in accumbens. Therefore, atomoxetine has no abuse potential. BUPROPION. It's a weak NDRI. Several tricyclic antidepressants have notable NRI actions such as desipramine and nortriptyline, but only atomoxetine is well investigated and is approved for this use in children and adults. It theoretically restores tonic postsynaptic D1 and alpha-2A signaling, downregulates phasic NE and DA actions, and desensitizes postsynaptic NE and DA receptors, and thus reduce chronic HPA axis overactivation and thereby potentially reverse stress-related brain atrophy. NRIs may actually be preferred to stimulants in patients with complex comorbidities. Alpha-E2 adrenergic agonists. There are numerous subtypes of alpha-adrenergic receptors, from presynaptic autoreceptors, generally the alpha-2A subtype, to postsynaptic alpha-2A, 2B, 2C, and alpha-1 subtypes. The alpha-2A receptors are thought to be the primary mediators of the effects of NE in prefrontal cortex, regulating symptoms of inattention, hyperactivity, and impulsivity. Alpha-2B receptors are in high concentrations in the thalamus and may be important in mediating sedating actions of NE. Alpha-2C receptors are densest in the striatum. Alpha-1 receptors generally have opposing actions to alpha-2 receptors, with alpha-2 mechanism predominating when NE release is low or moderate, that is for normal attention, but with alpha-1 mechanism predominating when NE release is high, that is when associated with stress or comorbidities. NRI at low doses will first increase activity at alpha-2A postsynaptic receptors to enhance cognitive performance, but at high doses may swarm the synapse with too much NE and cause sedation or cognitive impairment or both. Thus, lowering the dose of NRIs in such cases must be done. There are two direct acting agonists for alpha-2 receptors used to treat ADHD. These are Guanfacine and CLONIDINE. Guanfacine is relatively more selective for alpha-2A receptors, and only the CR version of it is approved. It allows for once daily administration and lowers the peak dose side effects. CLONIDINE, on the other hand, is a relatively non-selective agonist at alpha-2 receptors and also has actions on imidazole receptors, which is thought to be responsible for some of its sedating and hypotensive actions. Interestingly, it's not approved for the treatment of ADHD but is often used off-label. The best candidates for monotherapy with guanfacine ER are patients with low NE levels in prefrontal cortex, without additional impairment in DA neurotransmission. This would lead to scrambled signal lost within the background noise, seen behaviorally as hyperactivity, impulsivity, and inattention. And with Guanfacine ER, there will be increased signal via direct stimulation of postsynaptic receptors. And this would translate into the patient being able to focus, sit still, and behave adequately. Patients suffering from ADHD and oppositional symptoms can be argumentative, disobedient, aggressive, and exhibit temper tantrums. This is linked to very low levels of NE and low levels of DA in the VMPFC, thus leading to much reduced signal and increased noise. Augmenting a stimulant with an alpha-2 agonist will hypothetically solve this problem by optimizing the levels of NE. Guanfacine ER has been approved as an augmenting agent for patients inadequately responsive to stimulants and may be especially helpful in patients with oppositional symptoms. Future treatments of ADHD. These include enhancing prefrontal cortex histamine actions by blocking its presynaptic H3 autoreceptors and boosting acetylcholine function in prefrontal cortex. Other early stage pro-cognitive mechanisms being tested are ampakines boosting glutamate neurotransmission at AMPA receptors, 5-HT6 antagonists and PDE4 inhibitors. Several alpha-7 nicotine receptor antagonists are also being tested. Vortioxetine also has theoretical appeal as a pro-cognitive agent not only in depression but also in ADHD.